where it is and stuff, but it'll probably be in about 45 minutes or so. Any questions come up? You know what, in between you can always come up and ask questions. It's a little safer. Huh? All right. I'm that way too. Oh, hey, yeah.
What was the name of that book that you said, Primal Wound or Primal Scream?
No, not Screen. That's a different one. But that was one when we were in our hippie days. that was a rebirthing thing. Remember that? No, it was. I think it's called Primal Wound.
Okay.
And if you can't go online, you have your tablet. I don't have an iPad, but
I don't either.
okay. If someone go online and you can find who the author is and stuff. I just got off Amazon, so I have it at home. But if you can't find it, just give me your email address.
Okay.
Yeah. It's not a hard read, and it's really the topic and material. She gets through it pretty good. So, and it's not, and to be honest with you, it's not an uncommon event. I mean, I think many pregnancies are unintended, but I think the felt to be to be fair to the baby, that the baby should go with some parents that really can provide for the baby, and I know that's something that happens quite a bit. So, but I think it's an awareness, and I only talk about it because it's you realize things like that are below the surface most of the time, and I think everyone needs to work through what happened in the childhood at some level, and some things are a lot worse than others. Okay. So enough on that background. We're going to get on to some pregnancy issues. Pregnancy considerations. The continual cycle, I'm going to read this so you'll, because I may make some other comments. The continual cycle, thanks for taking that. Well, I appreciate that, because I couldn't see it.
I know, it was distracting.
Yeah, the continual cycle of addiction that occurs with intoxication and withdrawal. So do you understand when I say that, what I mean? Because it's an important concept I'm going to come back to. Intoxication is when I think we usually refer to as getting high. So that's the intoxication. And then the withdrawal happens as whenever that blood level, and this is your pharmacology talking, whenever that was great. You like pharmacology? About 10% of it did, maybe. It's a lot to do with what you do, what we do. So then as the blood level comes down, then the withdrawal begins to surface. So that continual cycle for the woman who's pregnant can produce ill effects on the uterus. So if you look at withdrawal, not only are there skeletal muscle that you can't really control, things happening, there's also involuntary muscles happening, throwing up, sweating, diarrhea, but the uterus also has involuntary muscles in it, so it's innervated by your parasympathetic. And the uterus, what do you think it's going to do during withdrawal? It begins to spasm. Blood flow decreases across the placenta. So that continual cycle during pregnancy puts the pregnancy at risk, the baby's growth at risk, the baby's neural development at risk, and later towards term can increase stillborn rate, certainly preterm birth. And all of those are consequences of people who we call it using during the pregnancy. So medication-assisted treatment has a big role in at least making the outcome for the pregnancy the best that it can be. So you're really looking at a fetus who really deserves a chance. At least that would be how you would look at someone who is getting into medication-assisted treatment. And methadone as the gold standard has been used back in the 70s for the medication-assisted treatment for the woman who's pregnant in order to have her quit using and get out of that intoxication withdrawal cycle. Babies are born to mom on replacement medication, are born full-term, appropriate size, and healthy. I think if the babies are a little bit undergrown, it's not the result of the opiate, the methadone, or now we see a lot of Subutex. It's probably more related to smoking. Exposed newborns. When I talk to moms prenatally, which is absolutely the best time to engage them, I really say, you know, all babies have withdrawal. Your baby will have withdrawal. It's more, the question is whether they will need, whether they can get through with just supportive care, or whether they're going to need an opiate replacement themselves or to detoxify. Okay, so here's a roadmap that I want to use for about the next half hour of dividing the continuum of care into two discrete time points of the perinatal experience of the mom and newborn. So we're going to go prenatal, delivery, storing and treatment, and then discharge. And this is, to me, I like to think of this, can we change the legacy for this baby? Or is the baby doomed to repeat this experience? So the only access you have to the baby's development and growth is either through the parents if they retain custody, or wherever the baby's placed, making sure that that baby has the best chance possible. So we have delivery or prenatal delivery in our 5-day observation period, treatment if that occurs, and I'll talk about how many we treat, and then discharge. So the two medications, I don't know if you know much about them. This is just a real thumbnail. Overall, I'm going to group the perinatal opiate exposures into 4 groups. It makes it a little bit more simple to understand these groups are not all or none, but there's methadone replacement, buprenorphine, and or Subutex. You realize when moms are pregnant and they were on Suboxone before they found out they were pregnant, then they get switched to Subutex. It just has to do with how currently prescribing is done, because Subutex does not have naloxone in it, right? And naloxone is an antagonist for opiates. The thinking is that if you combine an opiate, in this case buprenorphine, with an antagonist, that if it gets crushed up and injected, it'll precipitate withdrawal. So that's the thinking behind that, and it decreases the incentive for diversion. That's the whole thinking behind it. And to follow that same thinking, as soon as a mom who's on Subutex delivers, she switched back to Suboxone within days of delivery. So the 4 groups are methadone, buprenorphine or Subutex, prescribed opiates for chronic pain, and then illicit opiates. So with methadone and buprenorphine, the 2 that are used for medication-assisted treatment, methadone, they're both long-acting. That in adults, this is probably 18 to 30 hours. Buprenorphine is 24 hours plus. And patients can go a day without and miss a dose. Methadone is prescribed initially as daily using a liquid form, and parents can earn take-homes for up to a week. Buprenorphine is sublingual. It's usually those little strips that are like Listerine strips you put on your tongue and it dissolves. That's kind of the form that, one of the forms that buprenorphine comes in. With methadone, there's no ceiling effect, that patients can actually have some euphoria if they are taking more methadone than what meets their endogenous needs. With buprenorphine, there is a ceiling effect because it is both an antagonist and an agonist. So initially, up to probably about 32 milligrams, the mu receptor is the receptor for opiate that we talk about. That's probably the most active receptor, not only in the brain, but also in the intestine and other parts of the body. So the mu receptor will become probably about 95% saturated at about 32 milligrams of buprenorphine a day. Above that, then you get to have, there are side effects and also antagonistic, the antagonist part of buprenorphine will kick in. So if someone is switching from, say, methadone to buprenorphine, there's about a 3-day period in there when they will stop the methadone, begin to go through withdrawal during that 72-hour time period, and then start on buprenorphine. If they start sooner, then this will block the methadone and precipitate withdrawal. Okay. So and there are many people on methadone who get down low enough or once you go over to buprenorphine, because you can actually get prescriptions up to 30 days. And there are different effects, side effects that the two drugs have. Many people on methadone and have been on both of them will tell me that, oh my gosh, that methadone just really screws you up, and and I infinitely prefer being on Subutex or buprenorphine. So that's what I've been told, that, and particularly at higher doses, there are other side effects. But methadone is a pure agonist. This is the one that most of the time is the entry. If a woman finds out she's pregnant and she's using and goes to get into treatment, methadone is more likely what they're going to get on, although not all the time. We actually just finished a trial. We compared treatment of the newborn with either morphine or methadone. And I wanted to know, because our consent rate was pretty low in the methadone group compared to the Subutex group, I wanted to know, was it the moms who had just come into treatment during the pregnancy that were more likely to refuse or not? And it was actually a fairly low number would actually come into treatment after they found out they were pregnant. So probably about 20% of the moms who delivered on methadone, and it was actually the same number for Subutex. So I thought it would be higher, but the great majority of the women who delivered during that time, whether they were in the study or not, were on replacement medication before they got pregnant. And we certainly recommend not to wean during the pregnancy. And it's a very strong stimulus. I don't want the baby to get any more of this medication if possible. I want to wean during the pregnancy. And not only does the mom think that, but many of those around her, for her support people, like the baby's father or her mother, will push very strong for the mom to get off treatment during why can't you just stop? During the pregnancy. And we've had several pregnancies deliver early, or their pregnancy losses before 20 weeks. Certainly see smaller babies, placental abruption late in pregnancy, and occasionally stillborn with people who were on replacement medication. And you often wonder whether or not there was some attempt to wean, or they were missing doses or whatever. So those are the groups of opiates we want to talk about. And here's where, most of you seen this? You know where this is? At Eastern Maine. This is the atrium. This is a really neat area on pediatrics that has, it's such a great metaphor for kids. It's just, you get all the light comes in from above, And this is coming down the hallway, the nurse's station, and this is the Family Resource Center. In the NICU, these are the two places where we will take care of babies who have, who we're either observing or detoxifying, so that this is the front room in the NICU. The higher level of care, we have 14 bed spots on the 7th floor, and this is the CCN. You've been, you know, the CCN, continuing care. This is, it opened in 2005. These are single patient rooms, and there's 9 rooms up there. We can take care of 11 babies. That math works out when twins are in one of the rooms. So we can have 2 sets of twins up there also. All right. Now, I'm going to show you something here on the next photograph. That this is a picture that has been in the grant conference room. Is Jackie here?
No.
That's great.
I think in Florida, probably.
Oh, no. Is she
That's why she
in
wanted
Florida?
to cancel
I
Florida.
thought she was going, but I think.
So this says, and this was my iPhone picture, all right, I'm sorry about it. But this says 1992 to 1982, 1994, she was the pediatric head nurse at Eastern Maine Medical Center. And right here, it says, it talks about characteristics of Jackie, and I have a feeling they probably haven't changed. And I'll read them to you. Dedication, enthusiasm, competence, motivation, fairness, perseverance, leadership, and support. So I just wanted to thank Jackie for inviting me up, and when she had called and sent me an email, I said, oh my God, that's this picture that I've been looking at up there in the conference room. So she'd be happy to know that this is her legacy. She'd probably come and rip it down now. Yeah. Jim Hirschfeld had my job, chairman of pediatrics at that time. So that was a tribute to Jackie. And
We'll let her know.
I bet you will. You know, the copy of slides that I sent out, I took that picture out. I didn't want to ruin the surprise. All right, so well, what I said, whoops, let's go back here a second. All right, I have to go back. So this is the best time. During the prenatal period, it is absolutely the best time to engage the mom, to explain to her what's going to happen. She's very, very, very receptive to any and all teaching. So if you've taken care of moms who have delivered, you realize that in the 48 hours after delivery is probably the worst time to try to give them information, to have them absorb stuff about the baby. Any teaching we do during that time period is probably about 10% of it gets retained, and the 90% is for us to check boxes on our chart. It doesn't get retained. You think about when you're in a high emotion state and someone's trying to explain something to you, because this is going to happen the rest of your life. You're explaining, and they're in a high emotion state because someone just died or something happened to themselves or whatever. Your emotions just shut down your ability to function at the higher level that you can when you're at your best. Be aware of that when you're talking to patients when they've delivered. Really, if I'm talking to a newborn and they just delivered and it's a 28-weeker, I know that mom, they don't want to know about intracranial hemorrhage and apnea and patent ductus arteriosus and necrotizing colitis or any of that. They don't want to know that. That would be my purposes to be talking to them. They want to know, is the baby going to make it? That's really it. Is the baby going to make it? And I usually tell them, yeah, we can get the baby through this. The baby can make it. Not will, I don't have that crystal ball, but. So during the prenatal period, those emotions now are a lot lower and not fueling confusion, so you're able to give them more information. So I'm going to show you some of the numbers. I don't know if you like numbers, but to me, I can transfer a lot more information just showing you these figures than talking to you. I started a database when I came to Eastern Maine I learned how to do access. I made sort of a basic access database to put numbers into, and then got a lot of help making it a whole lot better database, and now someone else puts numbers into it for me. I'm going to go back for 5 years here. So 2008, 9, 10, 11, and 12. There are 717 babies in that database. So this is I'm talking from a position of a lot of numbers and some strength when we talk about what we're seeing and what decisions to make. And I think it's important anytime you're making decisions about this nature about patient care, you really have to talk from a position of strength. So these are just the frequency distribution. 42% of the babies were methadone exposed, 33 buprenorphine, 17% prescribed opiates, and about 10% illicit. Now that's what we know. There's probably others that have come through that we don't know about that weren't picked up, but these are the ones that we know about that we are able to track. Over time, we've had more and more admissions. I was able to find, there's probably a couple babies in 2002. I don't know that for a fact. The best records we had in 2003, we had 24 babies, and then in 2012, 182. We're probably actually a little bit below 182 in 2013. I haven't gotten those numbers yet. Yep.
I just have a quick question about, most of these mothers must not tell you that they are addicted, right? Do you try to screen them, or do they openly tell you?
Moms who are on medication-assisted treatment, we know.
Yes.
Not all of them necessarily will disclose to the prenatal provider, but we have a network that goes to Discovery House Metro and Acadia that we know. And when they're inpatient for 2 or 3 days, they will need to have it prescribed for them. But I'm sure there are some that, is that what you're asking?
There is mandatory drug testing for
Yeah.
pregnancy.
I'll talk about what we do.
Okay.
Yeah. So how do you screen for them? If you hold on a second, I'll get there. Okay, thanks for asking.
I have a question with our friend, with the opening of the Acadia Clinic, 2001, was that the day program for medication assistant?
This was the outpatient methadone medication assisted treatment program. Understand that methadone falls under federal guidelines. Suboxone is not. And if you have a methadone clinic, you have to have a counseling. You have to follow regulations in order to do that. If you are a Subutex Suboxone prescriber, then that's who you are. You have to get education, and I'll show you in a minute. Initially, you could have a panel of 30 patients, and then that got increased to a panel of 100 patients. I don't know why the regulations are different, but they're very different regulations, and I think most people prefer the Suboxone Subutex route, but those, if you're a prescriber, your patients don't have to have counseling. There's no mandatory regulations
Because
like
back to your slide previous, when you were comparing the two methadones.
Right.
So you said, that was one of the things that popped in my mind, where you had one that was a 30-day prescription, where the methadone, you had to be a lot of this and
actually, probably one of the programs that I've encountered that's probably the best is Open Door in Ellsworth. They do a very good job. The patient, the mom or whoever it is, mom or dad or no matter when we come into the clinic, and during the signing in part, there is prescribed counseling they have to adhere to, but they also are told you're going to be off in 6 months. LePage liked that. I think that, and when I've been over there and talked with them a lot, I asked them about that. What is your recidivism rate, your failure rate?
Right.
And unfortunately, they don't have that. So once people are discharged, who relapses, they're not able to really get that information. But it's a very good program and includes counseling. So, and they do it, I don't know whether that's on a grant or what that they do that on. So if I divide out the buprenorphine and methadone exposures, you can see that probably about between '09 and '10, we began to get an even distribution of buprenorphine and methadone. So more and more prescribers in the area. Up here, if there's any medication-assisted treatment, it'll be most likely would be a Subutex Suboxone prescriber. I know there's
Yes, we don't
there-
have the, no.
you're not gonna have, the nearest clinic is in Bangor, and Discovery House in Calais, and we haven't seen too many patients come from there recently, so I'm not sure what's happened with their program. But you do have Subutex Suboxone prescribers up here, and that's what you would see, which is not a bad thing. So here's things. This was buprenorphine was released. The panel could go from 30 to 60 in September '06, and then there was a trial that looked at randomizing mothers between. That's why it's called the mother's trial. I know that was a relief, right? Well, randomizing them between either methadone or Subutex. And the moms didn't know what they were on. So they went through a process, and they actually went through that 72-hour withdrawal process to get on one or the other. They were stabilized on morphine, and then I went through that process. And there was a high dropout rate in the Subutex group. What they did find was that the babies were less likely to have withdrawal, needing treatment if they were in the Suboxone group. And I'll show you, we actually have seen that same thing. So what are the issues when we try to take care of creating our NAS program? Given those numbers, what were the issues that we began to deal with? And I always like the thing of the low-hanging fruit. I think you wanna deal with the things that people are most interested in, to gain credibility, to get people involved in your process. And the first thing we did, trying to figure out who the community stakeholders were in this, and they were the people that were prescribing or the methadone clinics, and then those communities who were seeing the patients. And we had in our group when we started, we had DHHS at the table very early in public health nursing. And then we got Maine Families involved. And on the community, the community side, or the treatment side, we had some Center for Family Medicine who prescribed Suboxone, Subutex, but also then Acadia was a strong player in our program. And then the next thing we looked at was who got screened. Let me go back here. So who got screened, then confounders, assessment of withdrawal, changing conventional treatment, breastfeeding, judgment, and criticism. These were issues that I've listed that we had talked about. So the first thing were who are the people who are seeing these mothers in the prenatal time period, and who are the ones that are providing medication-assisted treatment. Obviously, it's hard to talk to a mom who's using illicitly when she finds out she gets pregnant, because she's not going to come forward at all. So we began doing anticipatory counseling with the moms. I think we now still only see about 20–25% of these moms at best who are on methadone or Suboxone, Subutex, or on prescribed opiates. It is absolutely the best time to sit there and talk to them about, here's what's going to happen, here's why, here's what we do about breastfeeding, here's what we do about treatment of the baby and observing, etc. And those are all the things we talk about. We talk about reducing smoking to less than 10 cigarettes a day. Our breastfeeding policy aligns with the American Academy of Pediatrics, so that you really can't have any illicit drugs in the urine drug stream. And we avoid the term dirty and clean. Those are judgment terms, right?
In regards to illicit and.
Yeah, illicit or not, yeah. Or even clothes. Oh, your shirt's dirty. Well, that's, in my world, that shirt's dirty, but in your world, that may be as clean as it gets. Your shirt isn't dirty. So, in other words, I think one of the very important things is to try to realize what terms we use that have judgment laced in it. Anybody think of any? Well, some recent ones that we actually did a conference a year ago, and I had a speaker, was a neonatologist from the University of Vermont, where they're doing outpatient treatment for 10 years. And she was trying to put her speaker phone on, and she said, she couldn't get enough, I must be retarded. OMG, that was a no-no. And she didn't know that, and she wasn't aware of that, but we got complaints, we got people that walked out, and so that's a word that you really don't want kids using, because then they're criticizing and judging another kid. I'll tell you something that's even funnier. Went to the grocery store, and there's it's like a cross between a grapefruit and something else. And, you know, it's a big thing, has real warty, what do you call that?
It's actually called ugly fruit, isn't it?
Huh?
Is it called ugly fruit?
Ugly fruit, right. So I looked at it, and I was in Hannaford. Go into Hannaford and see what they call that now. It's not ugly fruit.
Awkward fruit?
No, it's
Pomelo or something now, isn't it, or what?
it's called something else that starts with a U. And I couldn't figure that out. And then it dawned on me, oh my God, they don't want kids calling other kids ugly. Right? So, and so there's a big push to really be aware of when and in medicine, we don't talk, I've talked about obesity, but we don't talk about obesity. You actually can really get criticized very heavily. It's just a high BMI. Because again, obesity implies a judgment, right? So just be aware, if you can just begin to be aware of that. So dirty and clean urines we took off the board, now we call them negative and positive. Feels better. So in order to breastfeed, moms have to have a negative urine, negative for unprescribed medication. All right, we go through the scoring criteria to treat the baby, treatment and weaning, and try to involve their partner and family support, and emphasize very strongly not to wean. Yep.
Just to clarify, so if the mother is taking these, replacing like the methadone, so that means she could still breastfeed?
Yeah. Yeah. I'll go through that. I'll show you a little bit. You know, I think well, first off, for 9 months, the baby got those medications anyway, so they'll probably get them in a lesser dose. But I'll show you what happens to treatment rates in that. So the first thing is who do we screen? And you mentioned something about mandatory screening. This took us probably a year and a half to slug out this one about who are we going to screen. If we have 1,500 deliveries a year and it's $300 for a urine drug screen, which is sort of the cost, it's not what main care bills, but it's sort of the operant cost. So do that math for me. How much is that a year? We have 1,500 deliveries and $300 a pop. Yep. Yep. Yeah, it's almost $250,000 to screen. Well, that didn't seem very realistic, and I actually said, you know, what are we trying to find out from the urine drug screen? What are we trying to find out? Who all the naughty mothers are? We're going to pick up cocaine. We're going to pick up marijuana, etc. Does DHHS care? I mean, and if the drug-affected, drug-exposed baby reports out there, what do you do with all of those numbers? I think what we decided we cared about was whether or not mom could breastfeed. We wanted to know if she hadn't had any prenatal engagement, was there an exposure to the baby? If they were in a narcotic treatment program, it mattered to us whether there was evidence of relapse or not. Mainly for, is this going to be a suitable home for this baby? And then social red flags, children not in the home, domestic violence in the home, drugs in the home. And the first three, there's pretty good evidence in the literature that those are very good screens. The social red flags we came up with internally. So what's the value of having this sort of list up there? What it is, we decided we couldn't do all moms. I think in a smaller setting, if you have 200 deliveries, then it's a little bit easier to foot that bill. But people on your DHHS, et cetera, they have to care about what you're going to find out. So they need to be at the table early on before you begin to do that. But what we did is this takes us out of judgment. You don't, you're not, oh my gosh, we just had a lot of metal in her mouth, and or a lot of tattoos, or she's a little flaky, so we ought to do, it takes you out of that realm. You want to stay out of the judgment profiling realm. So these were things that we had evidence-based, and essentially you can it passes a straight-face test, so that's our policy. And we've gone through it, and that's our policy. Everyone gets treated the same. However, the first thing I had up here, I think, is probably the most important thing. Behavioral screening is the most important thing for all who enter prenatal care. It's actually been shown to be more effective than urine drug screen when moms come in for their first prenatal visit. You really are saying, what your parents, what your partner, I'm not going to remember all the 4 pieces, but you're where you are in your life, and are there risk factors, and let's talk about those. So it gives an opportunity for intervention, much more so than doing it at the time they're in labor and being admitted. And I think that for those of you who've been seeing the Snuggle Me series, we talked about the four P's plus, and it's worthwhile getting that hold of that article. If you need to, I can get you a copy of that. But there's other articles that have the same type of screening, behavioral screening. So, confounders. So what else, if we're talking about opiates, what else can look like withdrawal from opiates? The substances that don't cause any withdrawal symptoms, methamphetamines, alcohol, cocaine, and marijuana. They're not good exposures for the pregnancy, but there's no withdrawal syndrome that usually happens with those exposures. Non-opiate drug withdrawal, nicotine or tobacco, that's a big one. It actually it accentuates opiate withdrawal. SSRIs, antidepressants, and benzodiazepines. Those are actually probably harder to treat, or as hard to treat as opiate. So it's helpful to know whether those are exposures have also occurred and to the baby. As you
Benzodiazepine category, if you've got a mother with, bipolar disorder.
Right.
Is on that.
What we found out very early on is that if you have a baby who's exposed to a benzo, I hope you don't mind if I call them benzo. It's easier to say than benzodiazepines, and opiates. So if she's on methadone and Xanax for anxiety, we treat the benzo withdrawal first.
Okay.
We haven't done any long-term studies, but we've had probably half a dozen babies been pretty successful with that. I will tell you that there's been a lot less use of benzos to treat moms' anxieties during pregnancy. And we've had a couple mothers who have gotten themselves off of benzos using marijuana, and were on prescription marijuana for anxiety because it didn't cause the withdrawal syndrome. Okay, at the time of delivery then, we do a 5-day observation. that observation includes scoring. So we'll talk a little bit about scoring. Those of you who have been down to our nurseries or pediatrics may have been exposed to some scoring. The Finnegan scoring system is what we use, although there are probably 4 or 5 different ones total. This is the one we've used. It has about 21 different categories, and it is divided into 3 probably somewhat overlapping categories of neurologic excitability, autonomic hyperactivation, and gastrointestinal dysfunction. The gastrointestinal dysfunction has to do with mu opiate receptors in the gastrointestinal tract. This is just the firing off of the 2 sympathetic and parasympathetic nervous systems. So this is what it looks like. It's not the best reproduction, but if you haven't seen it, these are the categories here, and the weight that's given to a baby who has, say, a high-pitched cry, excessive, and one that has it continuous, so 2 and 3. You already get a flavor that this is probably not the most objective thing. It's not like a CBC where you get back a hemoglobin and a hematocrit. There is a little bit of subjectivity. Well, was this baby just a continuous cry, or was it just excessive? I don't know. So the parents, as I go through this, they very quickly will pick up that, you know, there's a little bit of grayness in here. Some others that are myoclonic jerks. So that's when, if you're falling asleep watching a basketball game these days about 10 o'clock at night, and you're just drifting into that twilight, and all of a sudden you do that, that's a myoclonic jerk. It has to do with central nervous system release of your spinal cord reflexes. So this is a scoring system. Just take it that every 4 hours there's a score that if the baby slept less than 1 hour after a feed, they get 3 points there. If they have an excessive cry, they get 2 points, and they may, let's say they have some nasal stuffiness or yawning, whatever. Those add up. What we care about is when they begin to score 9 or more points in a 4-hour time period. It used to be more, I think when I came, we automatically it would be almost an automatic treatment if they had several 9s or had a 12 or higher. Now we spend a little bit more time because we recognize how gray all this is, so looking at the baby to figure out whether we want to treat them or not. Let me show you a couple examples that we can harvest this type of graph from Power Chart. Over here is the Finnegan score. So this is 1, 3, 5, 7, 9, 11. And these are each one of the scoring time epochs. So this would be 8, 8, 5, 7, 6. So you can see how it is. And this is a baby's 1 day of age is when we start scoring. So this is a little kiddo that was born to a mom who's on methadone maintenance. We observed this kid for 6 days and before discharge. Essentially what you're looking at then is the pattern of withdrawal after delivery for this particular baby, all right? So I have several. I'm going to kind of go the same thing. This is one, methadone maintenance, 33 milligrams. We observed for 6 days without treatment. We really thought on this kiddo, this is 2 10s up here, so met threshold. We looked at the baby. Parents are really wanted to wait out. They were holding the baby a lot, etc. So I'm sitting there shaking my head after I leave the room thinking, boy, we're going to end up treating this kiddo, etc. But they were very committed, and scores came down. Mom's milk came in, and then the baby, on the 5th day, the scores just dropped out. I walked in the room as a different baby. So sometimes you're really lucky. You get the baby through this time period watching without treating, and the baby gets to go home with mom and dad. Here's one that we treated. Mom was on oxycodone for her own prescription, unprescribed for her own taking for back pain, a little easier to treat the shorter acting ones, shorter acting opiates, and was treated with methadone up here, and the baby then had a 12-day stay. So obviously I'm going to show you a nice one, right? That's what this was a good example. Responsive treatment. I'd say probably a third to half the time that's a good one. This one I just put on here yesterday afternoon. This is a baby I was just taking care of. Mom's on Subutex, and here's day one. Began to have withdrawal. Milk came in right around in here. Baby had a 9 up here and then came down, and then continued to. Actually, there were 2 3s, and the baby then went home yesterday. I've seen these babies enough, and I see them all the time, that you know the baby. If I sit there in the room, the acid test, if I sit there in the room and talk to the mom, and the baby sleeps through that. Because I have a voice that tends to disturb babies a little bit, so that's the Mark Brown voice test. So if they can pass that, then they're ready to go home. You know, and I oftentimes tell the moms when they're leaving, I say, you know, you're a good mother. You did a good job. You're my hero, you know, and I believe it. Okay, 5-day stay, what we cover in that, we talked about the urine drug screen, 2-day stay with vaginal delivery, 3-day or 4-day with C-section, scoring and treatment criteria we go over, maximize contact with the baby. Maximize contact. The baby knows mom by 3 or 4 days. They know contact with the mom, whether it's smell, whether it's voice recognition. Things are probably still a little blurry when you're 3 days old. But if mom isn't there and the baby's fussy, the baby has a nurse coming in, a different one, every shift. Those babies don't do as well as the mom who's there and dedicated. She's staying with the baby the whole time up on pediatrics. Breastfeeding, we'll talk about the response, and we talked about having a negative urine. We review the treatment, and our lesson learned here is the supporting breastfeeding and maximize contact with the baby. Okay? A little bit into treatment. We're kind of moving through this a little quicker, just in case you didn't notice. But these are the steps and what happens there, and I think it's important to cover. One of the things with the treatment is we challenge conventional treatment. And when I came in 2006, we were treating babies with phenobarb first, and then if that didn't hold them, we would treat them with dilute tincture of opium, called DTO. It's an alkaloid, so it's an extraction from the poppy plant. It is not very pure. It has about 10 different morphine equivalents in it, and it's have about 18% alcohol, and it's short acting. And at the time, there was a study published, and I'll just show you briefly a slide from that, that a lot of people were using, about 20% of the time using methadone, the rest of the time using morphine, and DTO was coming out of favor. So we felt like we need to change. I didn't like the idea of using phenobarb first because kids would go home, and we had a number of anecdotal reports at 5 or 6 months of age. The kids are still on phenobarb, and it's hard to wean them off. I think there's been some pretty good evidence that kids on phenobarb treated for febrile seizures prophylactically did worse on phenobarb by about 10 IQ points than those that were not treated with phenobarb, so that it's not good for the developing brain. So we initially we looked at phenobarb and DTO versus methadone. It was not a blinded study. Parents knew what the kids were on, but very clearly it was an equivalency sort of outcome that methadone was. We liked it better. It was the kids weaned better, and there was about a 2-day shorter length of stay, but we had only 40 kids in it, and there was enough variability. It didn't reach statistical significance. So about a year and a half later, we then just completed the study, probably a year and a half ago. We blinded, actually masked. Okay? I don't want to offend anyone, so we had a masked trial of methadone versus morphine. And I'll show you that one. But I think right now, I haven't done this. You know what? This was a new slide I added yesterday, and we're just gonna go on, okay? I meant to put that in later, and I didn't do very good. Yeah?
I have a couple quick questions about the screening before you get too far away from it.
Mhm.
It's not entirely clear, are there situations where there's a legal mandate to screen, and also do you need to get, if you're gonna screen, do you need to get consent, like signed consent?
The second one's easier to answer, yes. Yeah, the knowledge, mom needs to know. We're gonna screen, unless you object, we're gonna do a urine drug screen on urine because it's our policy, you meet our criteria. No, I don't want it? Okay, that's fine, you don't. In that case, we would do a meconium screening on the baby, and that she can't refuse that, because in that instance, we're doing what's best for the baby. So the concerns of what's in the best interest of the baby trump what the parents say. So if we feel and we're justified, we've run it through our legal, and that's our policy, that we do meconium on the baby. If mother declines a urine drug screen, then she just needs to know that we're going to do that because that's our policy. I don't know in the state of Maine of any instances where there's mandated urine drug screening. At the time they come in delivery, DHHS can, if they're involved and have an open case. They can't be involved in the prenatal period because it's their mandate. But once the mom's delivered, in the best interest of the baby, they would want to know whether mom's using or not. It can be part of their information gathering to say, we need to get a urine drug screen from mom and whoever else is in the home, make sure there's no illicit drugs in the home. I don't know if that answered that.
Yeah, there's actually one more, and I don't know if it's the best time answered or whatever you want to do. I was also curious what the criteria are in protocol for any involvement of child protective services.
The state's pretty clear. Any drug-exposed pregnancy, opiate exposed, that includes methadone, opiatex, prescribed opiates, illicit, or marijuana. However, a hospital interprets that law, that is reported as a drug-exposed baby to DHHS. It didn't used to be. That was a recent law change. It used to be drug-affected baby, in which case the baby had to be affected by the drugs, either go through withdrawal or be treated for it. So if they're now it's just exposed, and those numbers and names get reported to DHHS.
And then it's at their discretion whether
Yeah.
they
Whether they want to open a case or not. And it's very regional, so I think if you have any program here, you're looking into doing things here in the community, they have to be right up at the table. And I've actually, I think ours, I had the most experience with ours, and we've had pretty high level engagement with our DHHS, and I'm very supportive of the approach they take. We probably end up with about 5 to 8% of babies in foster care who are opiate exposed in the first year of life. Otherwise, they are either going home with a safety plan, so that the mom's involved still, and the grandmother may have primary care or whatever, but there's a strong push to kinship care. So our treatment, we really emphasize non-pharmacologic or non-medication, maintain weight gain, minimal stimulation, swallowing, bundling, rooming in. This is lights off, TV off, etc., to try to get kids through. This is just a potpourri of pharmacologic. We currently use methadone as our first-line drug. Surveys, I had mentioned, this is, the blue is a 2006 published survey of, in the U.S., 75, and they mailed out 102 surveys. You can see non-methadone opiates, about 60%, methadone, about 20%, and phenobarb was first line in about, probably about 15 to 20%. United Kingdom published a survey, 2008, same questions, and they had non-methadone opiates. This was morphine and a little bit of methadone, phenobarb. So these are the ones that people are using. The 2010 American Academy of Pediatrics recommended either methadone or morphine as your primary treatment for opiate withdrawal. Sources of variation in response to treatment: mom's opiate exposure, choice of feeding, breast milk formula, rooming in, which drug we use to treat withdrawal, and then genetic makeup. This again, just as a reminder, this is the profile of what we see: methadone, buprenorphine, prescribed opiates, and illicit. So follow these as I go through: treatment, percentage, and then effect of breast milk on the treatment percentage, and the effect of breast milk on length of stay. Okay? So this is just, again, from our database, 36 weeks and over. We lost about 100 kids out of that cohort, which is fine. So these are the kids that more likely to be treated. Kids under 36 weeks aren't as likely to be treated, so that's why I took them out. Our treatment rate for methadone is 2 out of 3, and it's about 50% with buprenorphine. Prescribed opiates about 1 out of 3, illicit about 45%. Number of kids that are treated over that 5-year time period. So now, breastfeeding rate. The breastfeeding rate for methadone, it surprised me, it was about 38%, 45% for buprenorphine, and only 30% for prescribed opiates. Breastfeeding was not exclusive breastfeeding. I defined that by any breast milk on the 5th day. And the reason I picked the 5th day is because we do a 5-day observation. And one of the questions I was asking was, is the intent to breastfeed, but that continued to the 5th day, does that impact treatment rate and length of stay if you are treated? Of course, you know the answer, right? I wouldn't be showing you these slides. So, treatment rate for the green is breast milk, of course, and blue is formula. So, 5th day of life, treatment rate for methadone, remembering overall it was about 65%. So this reflects that 38% breastfeeding rate. 51%, 50% breast milk exposed were treated, and about 75% of formula exposed babies were breastfed. With buprenorphine, it's the same pattern: 60% formula fed, 35% breast milk, 40% versus 16% in prescribed opiates. So it's a breastfeeding effect that holds up across those 3 opiate exposures. To be sure, there is some methadone that passes in breast milk, and prescribed opiates, we don't know about buprenorphine, but I'm not convinced that it's pure and simply that that effect. That in other words, the methadone in the breast milk is not what's totally decreasing the rate of treatment. I think to breastfeed, you have to be there. We know that rooming in has a strong effect on whether or not a baby's treated regardless of breastfeeding. So I think it has to do with the presence as well as the intent to breastfeed. And it's the same effect if babies are treated. This is our length of treatment here in days, that if there's about a 2-day or 3-day shorter length of stay on average for breastfed babies who are treated, about a 4-day for buprenorphine, and 4 days on prescribed opiates. So not only does it affect your treatment rate, but it also affects length of stay. And then methadone versus morphine. We entered about 31 babies in this study, finished it in October 2012. And what we found, this is a busy slide, my apologies, but If the mother was on methadone, baby was treated with methadone, 15-day length of treatment of opiate. Mother on buprenorphine was, the length of treatment was 13.6 days. With morphine treatment in the baby who was exposed to methadone, it was almost double, 27.9 days versus methadone. The buprenorphine exposed babies treated with morphine was 19 versus 13.6 days. So we've continued to use methadone treatment. Okay. I'm gonna wait on the genetic makeup because I think I want to let you guys have a little break before I lose people. And we'll come back and just talk about some neat stuff we were doing with genetics, and then we'll wind up, okay? Do maybe about 5 till, okay?
Yeah.